मैडम का इंट्रोडक्शन दे देते हैं.
Good afternoon everyone, myself Dr. Vaishnavi Pendur Kunde. Introducing Dr. Pratima Vishwakarma ma'am, MBBS DNB FECO. Ma'am completed MBBS from GMC Nagpur, followed by residency in ophthalmology from LVPI Bhubaneswar. She completed cornea fellowship from LVPI Hyderabad, followed by fellowship and observership from Harvard University USA, University of Germany and Bascom Palmer Eye University USA, and also acquired FECO cornea. She received IVT International Contest Award in 2018. She received LVPI Research Excellence Award in 2021. She is currently working as a cornea transplant and phaco-refractive consultant in SV Vishwakarma Memorial Eye Hospital, Nagpur, and Cornea Eye Care Clinic, Nagpur.
So, hello everyone. Hello everyone, and thanks a lot for inviting me. So, today I will be talking upon microbial keratitis. It will be very difficult to take the lead after Dr. Pratik Vishwakarma's presentation. So, first of all, we need to understand how to diagnose the condition as well as manage it. Before that, I would like to elaborate just a little bit on the anatomy of the eye. So, as rightly told by Dr. Pratik Vishwakarma, there are so many problems with the retina which can happen, and that is so important. But for the light to pass from the into the eye up to the retina, all the structures of the eye need to be clear and transparent. So for that, the vitreous cavity should be clear, the lens should be clear, the pupillary area should be clear, the aqueous should be clear, and the cornea, which is the anterior-most structure of the eye. So what happens if there is any corneal condition? So if there is any corneal ulcer, there may be discontinuation in the normal epithelial surface of the cornea, which is associated with necrosis of the surrounding corneal tissue. If there is just a discontinuation, we will call it corneal aberration, that is epithelial defect. But if it is associated with necrosis, then we call it corneal ulcer. So this corneal ulcer can be infective or it can be non-infective. We need to find and we need to differentiate between infective conditions and non-infective ones. The infective ones are called as microbial keratitis, and the non-infective one is basically sterile infiltration. So we don't need to start all kinds of antibiotics in the non-infective ones. A simple lubricating eye drop along with a little bit of the broad spectrum antibiotics like fluoroquinolone or chloramphenicol may be enough just to avoid any infection. Okay, and if it is non-infective, sterile, we have to see whether it is inflammatory or not. So I'm not delving much into this, and I'm going ahead with the topic of microbial keratitis. So what are the risk factors causing microbial keratitis? First of all, any kind of eye injury, that is trauma, can lead to epithelial breach, and this can lead to further infection causing microbial keratitis. Then this can be either bacterial, viral, fungal, or there can be many other causes. Sometimes some of the organisms, like for example virus and bacteria, doesn't even need breach of epithelium. Then if the patient is a contact lens user, these patients are also very prone to any kind of infection. What is the reason for that? Improper care of the contact lenses, the solution of the contact lenses, all these, if they are not properly kept, if the contact lens is not properly washed, if the use of the contact lens is like the patient is sleeping with the contact lens, then also it can lead to infections. Then another cause is foreign body entry into the eye. This is very common, especially in the rural population. So you have seen many farmers coming to you with microbial keratitis, and the main cause would be foreign body entry. Any kind of sand entry, any vegetative matter like leaf particles or any stem particles entering into eye, that can lead to microbial keratitis. And then there is poor immune system. So for all cases of microbial keratitis, we should rule out immune-mediated immunocompromised states and also diabetes mellitus, which can lead to neurotrophic keratitis. The cornea sensations might be lower, and that can also predispose the patient to microbial keratitis. Now then, what are the symptoms of these patients? The patient first will present with severe eye pain in most of the situations. Sometimes though, in fungal keratitis or in viral keratitis, the patient may be asymptomatic. Then there is photophobia. If there is any kind of corneal edema, then patient will tell you symptoms of photophobia. That is whenever they go in the sunlight, they have a lot of difficulty. Then blurring of vision, that can be slow, gradual, progressive, or it can be sudden if the organism is very virulent. Redness of eye is something which you can directly see the patient coming with redness of eye, swelling of lid, and they will tell you about that. Discharge may be there. It can be just watery discharge or it can be mucopurulent. Then the patient will have eye discomfort. Signs would be, first of all, the simple signs. You can see some marks like the discharge around the eye, corneal inflammation, that is redness as I already said, and redness would be there over the conjunctiva, over the sclera. There will be some redness around the eye also sometimes if there is lid edema. So we have to see all these signs. What are the major specific signs which you can see in microbial keratitis? Obviously this picture. So what do you need to see? This is corneal infiltration. Okay? So it can be whitish, it can be yellowish, which will indicate a little bit towards the diagnosis also as to what is the organism. You have to see whether this is a circular infiltrate, whether this infiltrate is associated with a satellite lesion which is an extra infiltrate just around it. Then how is the margin, whether it is punched out or is there a feathery margin. What is the size of the infiltrate, whether it is a small one, a huge one, what exactly is the size. Whether this is central, peripheral, pupillary involving, and then again, if there is any presence of hypopion or not, which will indicate towards the severity. Along with the infiltrate, you can see here that there are some folds, okay? So this indicates that it is going up to the descemet membrane. So though it is visible as it, we can see that it is a very small infiltrate, but since it is going up to the descemet membrane, this is a deeper infiltrate, so we should not take it lightly. So the causative organism, this is very important. So what happens whenever a patient comes to us, many a times we start on all types of therapy for the patient. We will start on bacterial, antivirals, antifungals. This is not necessary. Even with clinically, we can see that what kind of organism is there. So round, oval, whitish lesion with a history of contact lens use, dry eye, aberration, or sometimes even if there is foreign body entry, we can think of a bacterial keratitis. There can be presence of hypopion, it may be present or not. The hypopion is usually straighter in the bacterial lesions. Then, jumping on to fungal first, there may be a history of vegetative trauma more commonly in fungal. As opposed to bacterial, it can be any kind of trauma, but vegetative trauma, especially with like wooden stick, leaf, sand particle, anything entering into the eye, directs us towards fungal. You can see here that the margins are feathery, which are very important. If you see a feathery margin, you can think about fungal, but not always. Sometimes early viral keratitis can mimic like a fungal keratitis. And sometimes these kind of pictures where you can see dendritic lesion, and as I've already shown here that it is viral, this can be also sometimes you may see that it is pseudodendritic, the knobs are not perfect, and then again later on you will see that this patient actually is fungal rather than viral. So it can be mimicking. So we have to see the findings very clearly as to whether it is fungal or viral in the initial stages especially. So this is a fungal keratitis picture, and then there is viral, where usually there are like it can be either epithelial or deep stromal or endothelial. So in epithelial lesions, it will have a dendritic appearance. So viral composes either we can see HSV or HZO, right? So usually HSV will have proper dendritic lesions with knobs at the periphery. While pseudodendritic lesions may be present in HZO, it can be present sometimes in Echinus also. Some protocol conditions might start like a pseudodendritic lesion and then later you can see the proper findings, right? Like ring infiltrates. So many a times it's not very specific. what you are seeing and what is actually happening. There can be some mimicking factors. So a ring infiltrate usually directs us towards protozoa, that is acanthamoeba keratitis. And the most common factor for that would be contact lens use. So as you can see here, a complete ring infiltration. This here we know the diagnosis is acanthamoeba. Sometimes even here there can be mimicking factors. A ring infiltrate can be seen in sterile infections. It can be seen in viral infections sometimes. There can be ring infiltrate in fungal infections, some different kind of organisms like Pythium. So not always that you will see this picture and this will be still classical. But yeah, this one is classical and this is acanthamoeba. But sometimes there can be mimicking factors. So this is an unusual organism, Pythium. If you see this organism, it looks like fungus, but it is not. Okay, so you can see small reticular dot-like opacity. The patient will present with treatment with antifungals for maybe a month or two, and later on when we scrape, when we see, instead of again on scraping, you will see some filamentous organisms, but the morphology will be different and the treatment is entirely different. So for fungus, we will give antifungals like natamycin, voriconazole. But for Pythium, what do we give? That is antibacterial, linezolid. Okay, so though the organism is similar, the picture is so similar to fungus, but the treatment is entirely different. So a long-standing patient with this kind of clinical picture on antifungals, we have to suspect this organism. Not so common in Maharashtra, but many places in India have this organism quite commonly. So this is another classical appearance, windshield appearance, very rarely seen. The diagnosis here is mycobacterial keratitis. What you can see is these long projections which appear just like a break in the windshield, and so this leads to a diagnosis of urtical mycobacteria. Once again being treated for long duration, but the treatment for this one would be amikacin, and for most of the bacterial, what do we give? Moxifloxacin and other fluoroquinolones. Then we can give vancomycin, but for this one, the treatment would be different. Amikacin is the first line, and then we can start along with fluoroquinolones and amikacin, a combination of treatment. Then this is nocardia. It gives a wreath-like pattern of appearance. Again, this is an unusual organism, not very commonly seen, but we have to keep these different organisms also in mind while treating the patient. So this is quite common in some of the places. You will sometimes even see that there will be a small kind of epidemic that some of the patients, some of the villagers are going into one pond, they are coming out and they are coming with this kind of clinical picture. Even in rainy seasons, this might become quite common. And you have to differentiate this with adenoviral infection. Many a times patient will come with this punctate lesions and we will think that this is just simply adenoviral. But what is the difference here? The lesion would be there will be stuck-on lesions. These are basically above the epithelium. What we see in adenoviral, they are under the epithelium, they are subepithelial. These are over the epithelium. So these stuck-on appearance is basically diagnostic of microsporidea. And what is the treatment here? Any guesses? Any guesses? Any random guess will be fine. So it's very simple treatment. You don't give any kind of antibiotic or anything for this. You just give copious amount of lubricating eye drops and this will be gone in maybe a week or two. Rarely it can have some inflammation in the anterior chamber, but that's not very common. And some people might give steroids thinking that this is like adenoviral, but that is contraindicated in this case. It will not resolve if you are giving steroids. You have to just put this patient on lubricating eye drops. So we have to differentiate this. Microsporidia can also be deep stromal. These are very difficult to treat. So what happens? They will have whitish, long-standing, diffuse multifocal infiltrate, waxing and waning pores, and this kind of clinical picture. So these are deep stromal conditions of microsporidia. So there are so many differentials, so many organisms causing microbial keratitis, and how do we know what exactly is there? So we need to go for a screening for these patients. what do? We take a 15 number blade, we scrape the anterior surface. Where do we scrape? I will tell you properly. And we take smears for the scraping sample, and then we examine it under microscope. Even that can be done by ophthalmologists, by others. Not necessary that microbiologists are always required, but yeah, they can help us to reach a definitive diagnosis. And then, as per whatever is there on the smear, we can start on the treatment first line, and then we can wait for the culture reports and give a definitive treatment accordingly. So, where do we scrape? First, we have to remove the debris, whatever is present. Then, we scrape along the base of the infiltrate and then along the edges of the infiltrate. So, this is the area which you will concentrate for scraping: the center, base, and just the periphery. Okay. We take it on a slide. Like for gram staining, we take a very thin smear, and for KOH staining, we take a thick smear. Like whatever we have taken, we just put a dab of that over the slide, and we don't make it we don't spread it out. For gram stain, we spread it out completely. There's another stain which we are doing now, that is trypan blue staining, that helps with identification of fungal filaments. So these are the other media which we take for culture. We take smears for gram and KOH, some smear on the solid agars like blood agar or chocolate agar or any, depending on what we are suspecting. Then these are mainly for bacteria. Then this mainly is for fungal infection, that is PD and SDA. For acanthamoeba, if you are suspecting that, if there is any patient with contact lens wear, history of contact lens wear, and there is a prominent ring infiltrate, we are suspecting acanthamoeba, we take sample on NNA also. And then liquid media like BHI, thioglycolate broth, and Robertson-Cook media. So these are the media which we can utilize. Not all media are required, but at least one solid media like blood agar or chocolate agar, one media like PD or SDA, and one liquid media would be great. So we need to rule out from these that what kind of organism is there, and a specific treatment can be started. If we find fungus, what do we start? We can start on natamycin, voriconazole, ketoconazole. These are basically dependent on the depth of infiltrate. Like if the infiltrate is just superficial, we know that there are feathery margins, we know that there are satellite lesions, it is classical of fungus, we can start on antifungals like natamycin. If it is superficial, only natamycin. If it is deeper, we can start on voriconazole, but the problem with voriconazole is it can lead to perforation sometimes. So we have to be very, very careful. If it is deeper, we can also start on systemic medications like tablet, ketoconazole, itraconazole. For pythium, as I said, the treatment is quite different. Acanthamoeba, we have PHMB chlorhexidine. We can also start voriconazole alongside depending on the situation. Microsporidia, as I said, for superficial lesions, nothing to be done. Just lubricating eye drops. Hourly, copious lubricating eye drops. For deeper lesions, the treatment is fumigatin, not very easily available, or voriconazole. And then a typical bacteria, amikacin would be a good choice for a typical mycobacteria or nocardia. And then actinomycetes, that is nocardia, we can give amikacin. But if we can rule out all these based on the clinical finding and on the scraping, we can simply start the patient on a very broad spectrum antibiotic. What would be the first line of choice? You can give a simple fluoroquinolone like moxifloxacin if the lesion is smaller. If the infiltrate is larger, then definitely go for fortified vancomycin along with ciprofloxacin. The problem with fortified vancomycin may be the formulation. Okay, cefazolin is easier to formulate. You just put distilled water in the vial, but again here the problem would be availability. So a combination of vancomycin with ciprofloxacin or cefazolin with ciprofloxacin is very good. But since it can be a little cumbersome, you can start with fluoroquinolones. Don't start like 4 times a day, 5 times a day. It usually doesn't help. 2 hourly or hourly dosing of fluoroquinolones is something which will help in the patients of microbial keratitis. Along with that, another medication which is important to decrease the inflammation would be atropine eye drops. Okay, atropine or homine, and always tell the patient that they will have pupillary dilatation and so photophobia and decreased vision if you start on atropine or homine. Otherwise, the patient will come back to you with these complaints. Then if it is not responding, then rescaping is something which we do. And if we have no organisms visible on the smear examination, on the culture, the patient is not responding to treatment, we give a drug holiday and we repeat the scraping. Sometimes even corneal biopsy may be required in certain conditions. So these are some of the examples where I have seen the slides personally, because I was telling you that not always that you need a microbiologist to see. So if you are in a very rural setting and you know how to see the smear, then you can make the do the gram staining yourself or put a KOH on the slide and you can see this. That here you can see some gram positive cocci, then here gram negative bacilli are visible, cocci, bacilli both are visible in this slide. Fungal filaments are seen on KOH staining, on trypan blue staining, and on, though the slide is not very clear, but there is a fungal filament here on gram staining. So gram staining would be like a first choice because you can see almost everything on it. Here you can see microsporidia, these are like rice green appearance with knobs at the end. Then these circular structures, double-walled cysts, are called as acanthamoeba, which though rarely seen are very important finding because the prognosis is not very great if they are diagnosed late. So this is another thing which is not directly related to microbial keratitis, but demodex can be seen on smear examination, and these organisms are seen on the hair lashes, eyelashes, and if we take the eyelashes, sometimes in the muck of the eyelashes we can see these organisms after putting KOH on the slide. So these organisms, though they don't directly cause infection, but they can cause like marginal keratitis kind of picture, which is called blepharokeratoconjunctivitis. And if small dots are seen on the cornea at the periphery, and there is a lot of blepharitis and scaling of lashes, this can be one of the causative organisms. So why is this important? As I told, a cocktail therapy with many medications like antibacterial, antifungal, antimicrosporidial, antipythum, antiviral, antiacanthamoeba medications. If we give all these medications together, though sometimes there can be still resolution, but many times this leads to a lot of toxicity. If it is fungal and you give antibacterial along with fungals, along with lubricants, sometimes instead of resolving, it becomes deeper because the actual medication which is required, that is the antifungal, is not penetrating into the organism and it is going deeper because there is epithelial resolution but the organism is going deep. So a cocktail therapy is not very helpful most of the times, but yes, in rural settings even that is important sometimes, that we at least start the patient if we are suspecting fungal infection, at least start the patient with moxifloxacin and natamycin and see ahead. But not many medications, as few as possible would be better. So a targeted therapy, we can reach to that if we have a proper diagnosis after corneal scraping. Okay, and we can at least after seeing the smear, we can start with, if we see any organisms, we will start specific treatment. If we don't see any organisms at all and we know it is a micro-infective case, then we can start with either fluoroquinolone, moxifloxacin, or we can start with a combination of broad spectrum, that is vancomycin, ciprofloxacin, or cefazolin, ciprofloxacin. This will cover, the vancomycin part would cover the gram-positive organisms, ciprofloxacin will cover the gram-negative ones. Then there is more specific treatment as per the culture sensitivity. If the organism is not responding, it might be resistant to it. So the culture reports will be usually followed by culture sensitivity reports and we can change the medications according to that. So as you can see here, if you give, a proper treatment is given, this large infiltrate also resolves to this level and the cornea is almost absolutely clear with a very minimal level of scarring and a very good outcome. But then again, it is not so straightforward, and sometimes even with the perfect management, with the perfect, like the patient is taking the medications properly, the compliance is good, everything is good, the medications are being given perfectly, still there can be conditions where the infection can increase, there can be a complete infiltration of the cornea, there can be perforation of the cornea, and then we might need treatment like surgical management, like therapeutic penetrating keratoplasty. So the options, first line would be medical management with broad spectrum antibiotics, second would be targeted therapy, and if it is not responding, if it is bacterial or so, then we can go ahead with the lamellar keratoplasty. For fungals, usually we never manage with lamellar keratoplasty, we always go for full thickness keratoplasty, that is TK. So what should you do when a patient comes to you? First of all, always check for the risk factors. If there is any foreign body which is there over the cornea and you need to remove it. If there is any history of trauma, you should know it and what kind of trauma is there, like whether it is an organic foreign body or whether it is a non-organic foreign body. That can lead us to a diagnosis. The organic one more commonly would be fungal, and a non-organic one would be more commonly towards bacteria. So diabetes mellitus is very important to check. Always check for RBS, whether the blood sugar is high, whether the infection which is increasing, not responding is due to uncontrolled diabetes. If the patient has a contact lens pair, as I said, it can be due to acanthamoeba, and another one would be simply bacterial. Sometimes, rarely, I have also seen microsporidia in such cases, but that is not so common with contact lens wear. Then, if the patient is on any medications and the medication itself is like there is some infection in the medication, it can also help us in the diagnosis. So you should always keep the medication vial with you. If the patient is already using a medication and after that the infection starts, then you can ask the patient what medications you are taking, and you can send that medication also for culture. Okay. So any chemical injury, toxins entry into the eye, that can also be checked for. And so once you see these patients, check for the risk factors, then you start on broad spectrum antibiotics. You can start on, as I said, for very smaller infection, if you see hardly any infiltrate, you can simply start on a soft antibiotic like chloramphenicol. For a slightly larger infection, simple fluoroquinolones are very effective, but start it at least 2 hourly, 8 times a day or something like that. For higher infections, fortified vancomycin with ciprofloxacin combination or cefazolin with ciprofloxacin combinations are helpful. Then again, if you are seeing that you are suspecting a specific organism, then you can add upon natamycin or so on. Okay. Apart from that, amikacin and all those medications I would not suggest for the first hand, like amikacin or maybe like as I said, PHMP chlorhexidine for acanthamoeba. All these are medications which are not so easily available first of all. Then I don't even suggest them first hand because it can cause a lot of toxicity. So we have to be very specific while starting these medications. A microbial diagnosis followed by these antibiotics would be helpful. And early diagnosis is important. Treat the patient, but if it is worsening, then a referral which is earlier to a cornea specialist before the infection is very large is very important, because many times we will get patients who have infection which is spreading up to the sclera. The prognosis after it has gone beyond the limbus is not that great. So therapeutic penetrating keratoplasty is not a magical surgery. Though it is a transplant surgery, the prognosis is usually very poor in these cases, because first of all we cannot give steroids right hand. Like after surgery, we need steroids for the graft to survive. But if it is a fungal infection, 2 weeks post surgery we cannot give steroids to such patients. So the graft survival is very low. Okay, so mostly these patients will have a pain-free period after surgery, but visual prognosis is hardly much. Okay, so in only maybe 20 to 30% of the cases we have seen, or even lesser than that, the vision is good, and maybe most of the times the graft will fail and we require repeat surgeries for this case, and every repeat surgery will have a higher chance of failure. So always check if there is a large infiltration, if it is going up to the sclera, then refer it early before it reaches the limbus. Okay, and then most important is always avoid steroids. Okay, so when is steroid helpful? Any idea? Like in which cases do we definitely give steroids? If there is an infection and we have to give steroids, what would be the case? So if we know the organism, like we know it is bacterial, it is viral, we are short, like we know that this is bacterial, this is viral. That is the time when we give steroids, or we know it is a toxicity, not a pure corneal infection, but it is not an infection, it is a sterile infiltration. That is the time when we give steroids. Okay, so in all other situations when we don't know the organisms and we are starting broad spectrum antibiotics and we don't know the response, then steroid is absolutely contraindicated. Starting steroids will lead to increase in the infection. Why is that? Because it will reduce the local host immune defense and it will contribute to the progression. It can lead to, the infection can become much more severe. Sometimes, as I said, the epithelium will start healing, though steroid will also prolong the epithelial healing. The infection can start going deeper. Okay, and then it will be much difficult to treat because the actual means antibiotics which are required to treat won't penetrate deep enough. So that is why we should absolutely avoid steroids unless and until we are sure of the diagnosis. In HSV, as you rightly said, steroids are required if it is stromal HSV or endothelial, but in other conditions we should avoid giving steroid. Okay, even with dendritic lesions, we don't give steroids. In HSV dendritic lesions, we will only give a cyclovir eye ointment, and that would be enough. And for any stromal infections, we can give on tablets also. Tablet cyclovir 5 times a day. So, early diagnosis is important. We need to identify the risk factors. We need to start broad spectrum antibiotics, which are and specific drugs if we know the diagnosis, and avoid steroids absolutely. Refer the patient before it becomes too large so that the prognosis would be better. And that's it. So thank you. So, any questions? I know it is quite near to the lunch time, but if any questions are there, I'm happy to take it. Thank you.
थैंक यू मैडम। क्वेरीज है, किसी को कुछ पूछना है? नहीं, सब समझ गया। चलो अभी लंच करते हैं ना, 1 मिनट ना।
थैंक यू डॉक्टर प्रतीक यानी मैडम। यहाँ पे सभी जो डॉक्टर्स है, कोई सिटी में है, कोई पेरीफेरी में प्रैक्टिस करते हैं, तो बेसिकली कौन सी केस है जो अपने पास रखना चाहिए और कौन सी केस को रेफर करना चाहिए, ये भी हमें आना चाहिए एक्चुअली। ॲज पर रेटिना डिसीज मराठी ॲक्च्युली क्लिनिकल डायग्नोसिस हे खूप महत्त्वाचं असतं, कारण आपण जेव्हा पेरीफेरीला प्रॅक्टिस करतो तर किती पेशंट म्हणजे पेशंटला आपल्याला किती दिवस आपल्याकडे ठेवायला पाहिजे ॲज पर विजन कन्सर्न. तर तुम्हाला क्लिनिकल डायग्नोसिस असलं तर तुम्हाला लगेच रेफर करायला पाहिजे है ना. आता रेटिनाचा कन्सर्न आहे, आपण रेटिना डायग्नोसिस तर करू शकतो, डायबिटीज रेटिनोपॅथी असो किंवा CSR असो, या केसेस आपण जर डायग्नोसिस केलं तर आपल्याला पेशंटला सांगता येते की तुम्हाला लगेच डॉक्टरांकडे जायला पाहिजे. खूपदा असं होते की आपण त्या पेशंटला NSAID देत बसतो, बरेच दिवस आपल्याकडेच ठेवतो आणि पेशंट